for us to move on to the next presentation. And we are going to have a presentation on a collaborative telemental health program from Krista Strait, Higgins. Thank you very much.
Hi, I'm Krista Strait, Higgins with the ALS Association Iowa chapter, and I'm going to speak with you today about our collaborative telemental health program. I have no conflicts of interest or financial disclosures to report. Having worked for the chapter for over 10 years, I feel that mental health counseling is one of the most underutilized supports by individuals living with ALS and their loved ones, and therefore wanted to develop a program that introduces the benefits of counseling while also increasing the access and use of counseling by our clients and caregivers. In 2015, our chapter went through a major overhaul and started to look at our mission and our key objectives and goals for each department. In that process, we identified the need for increased access to counseling services. Iowa is a very rural state with very small towns and communities throughout the state, and we have a limited number of counselors in those rural communities. So clients, if they want to access counseling, have to drive a distance to a larger community. And this presents an issue because first, you have to have wheelchair accessible transportation often. And also it becomes difficult to drive a distance as ALS progresses, not only for the client, but for the caregiver. Then finally, we have the majority of our clients have Medicare as their primary insurance. And before COVID, Medicare was not covering telemental health services or telehealth services of any variety. We have many established collaborations with graduate level university programs, and they have expanded the support and services we offer our families over the last 3 years and will continue to do so into the future. Not only are we supporting our families actively on learning about newer equipment and resources in regards to communication and assistive technology, but we're also educating these future healthcare professionals about ALS and the care, the best practice in caring for families impacted by this disease. So it was quite intuitive in 2018 when we started conversing with the University of Iowa Rehab and Counseling Program about taking on an intern who could provide telemental health services to our families. Originally, we had hoped that the intern would shadow the mental health counselor who attends our ALS clinic at the University of Iowa, but administration wasn't feeling that was a good fit for the interns and for the university. So our chapter independently connected with the counseling program to discuss taking on an intern for this purpose, so on our own. The plan originally was to access a compliant telemental health platform that was HIPAA compliant so that we could offer the virtual sessions through this platform and the interns would have a place to record their clinical documentation. Funding was an issue. Our chapter couldn't afford the cost of that kind of a program as well. We really didn't want to see the clinical record. So if we paid for it, we didn't want to have access to it. We wanted the interns to have access to it, but not ourselves. Also, when you consider funding, you have to consider the laws that are in place for each state about healthcare documentation, how long you have to hold on to that documentation, that record. And when it comes to mental health storage, clinical records, they have to be held for quite a few years. I believe it's like 7. It's kind of like taxes. You have to hold on to them for a while. So you have to consider supporting the cost of that platform for many years after your last appointment. So there's an MOU that's in the process between the university and a web platform company currently, but when it was April 2020 and COVID hit more strongly here in the United States, and they softened the parameters providing care through a telehealth platform, we decided to launch this program without a HIPAA compliant platform and worked through Zoom. Also, we didn't have any storage documentation. Our chapter didn't want to be responsible for storing that personal information. So the Qualtrics platform through the university was utilized, and the clients interested in accessing services completed the consent to receive an intern care, as well as our volunteer agreement, chapter volunteer agreement on that platform. Also, the interns charted in a coded and de-identified way their clinical documentation on interactions with clients in that platform. So the plan through the university was to they created a comprehensive intake and referral form for the interns to use. But again, we have no way to share that information confidentially. And our chapter staff really don't want to have the information or gather the information that's requested on that form. So instead, we implemented a different plan for referrals and access to the support. I completed an email to all the clients. And in April, we just worked with caregivers. The goal is, of course, to serve both clients and their loved ones and offer them both counseling. But we piloted with caregivers because we started this program in April of 2020, and we're over halfway into a semester, the spring semester for the university. So we simplified and offered to caregivers. And so I sent an email to caregivers and explaining this program and requesting return email if they were interested. Also, our staff called and interacted with others that maybe didn't have email and explained the program. So we used a color-coded spreadsheet system for referrals. I would enter the name of the person, their contact information, where they live, their phone, and their email, and made it red and covered the cells in red. And then the intern accessed that through a shared drive, and it's password protected, and would mark the cells yellow if once the intern spoke with them about the consents and the agreements, and then turned the cells green when they started counseling and all the consents were signed and completed. The university created a Google account that offered a confidential email and call platform for the interns with the clients. Our chapter facilitated ALS education for the intern, 90-minute webinar. We have a navigating ALS resource, a document that's full of detailed information and resources for clients living with ALS and caregivers, and we review that resource with the interns. And then, of course, we're offering weekly supervision to the interns and education for them on a weekly basis about the different nuances of serving someone with ALS and their loved one. We utilized a brief solution-focused model of therapy because we're only working with them a semester. The goal is that we're not serving anyone who's actively accessing counseling from a professional. And we had a couple people, caregivers, actually apply for services when they already had a therapist they were working with, and so we declined to serve them. This is a semester-long model. The goal is that we want people to access counseling from a professional in the future, not continue with just the interns for their care. Also, we have some limitations. Our chapter has some limitations on the kind of supervision we will offer. We don't provide direct health care through our chapter. Therefore, I wasn't comfortable doing observation of a session between the intern and a client. And also, I'm not comfortable reading any personal information in a clinical record. So the type of supervision I'm offering is approaches to interacting with the identified needs or of the client and the intern, education to the interns about boundaries and ALS in general and the process of care. So the University of Doctoral candidate shares supervision with the chapter, and that candidate offers the session observation that's required for this internship and also does the clinical record review. Our chapter has a volunteer program. And so to provide an extra layer of liability protection, we have each client interested in accessing this counseling agree to receive a volunteer, and each intern is vetted as an active volunteer through our chapter. We have a memorandum of understanding that we completed between the university program and ourselves, and each delineates what we're responsible for. The university created a training module for the students on individual counseling. And then at the end of each semester, if clients decide to access continued counseling, it's a joint effort between myself, the university doctoral candidate, and the students in identifying counseling resources for these individuals. In the fall, because we had a full semester we were working with, and we also had 2 interns versus just 1, we offered this opportunity to clients living with ALS, the caregivers, and also surviving caregivers. So anyone who had a death of a loved one within 6 months, in the past 6 months. Also, in the referral spreadsheet we used, we added a section to note client communication impairment, because we did have some clients that had speech impairments and it required special types of interventions to engage in therapy. And one of our interns completed a specialized educational series, which I was really excited about and still excited about, Caregiver Communication and Coping Skills Lab, in which they're providing training on direct communication skills, practicing with the caregivers. They offer education on how to set boundaries and self-care tactics, and they actually practice these it was a 6-week course series, and it went very well. The process improvements. We had some communication glitches, especially when we had 2 interns, because they shared the email and phone account, Google account, to the university. And so if one was taking care of the ALS client and one was taking care of the spouse and individual sessions, trying to schedule an appointment became a little bit of an issue if the client and spouse shared an email. So we had to identify a way to specify who the communication was for. So when the interns would reach out, they would put in the subject line who the intended party was of this communication. We had caregivers attend client sessions, individual sessions, many times to assist with communication, but this became a bit of an ethics issue, and the interns had to learn how to navigate speaking with both of them about how this was not couples counseling. They weren't providing couples counseling, they're providing individual counseling, so would direct all communication and care to the individual that the session was scheduled for. And also we will be including more details about how the interns are expecting to receive respectful communication from each person they work with. I'm sorry that we have to write that out in a consent, but it is necessary. We had a couple of people that were a bit naughty with our interns, and we need to address that. There was a need for an open sharing caregiver group. Our chapter used to facilitate a caregiver group, and we didn't have much attendance. But after the educational session, more people were interested in that type of sharing. So we either are going to piggyback that with the educational session, or we're going to offer a separate group for open sharing for caregivers next semester. Also, we're considering offering a frontotemporal dementia educational series, and evaluations are going to be handled a bit differently. From the inception of this program, the interns were asking evaluation questions at the end of each session, which kind of skews the results because they're there hearing what the client is saying. So the Iowa chapter will be completing the evaluations at the semester end via SurveyMonkey henceforth. The benefits of this collaboration are financial efficiency, free counseling for the families, no extra cost for the chapter. Definitely, we've improved the access to counseling. I mean, there's no excuses. They can do it from the comfort of their own home via a phone conversation or virtually over the web. Even we had a client who texted during their support with the intern. We're improving mental health care for clients, and specifically for those impacted by ALS. We're giving the specific education on ALS to the interns. They're getting valuable experience serving the population, and they're also getting that ongoing supervision from a chapter representative who has worked with ALS community for a while. So that's very much immersed into understanding ALS. And then the caregivers are getting a lot for their free support. Direct communication skills, boundary setting education. I mean, I can't even imagine. I just love that we offer that. And I wish that I had that actually. And then in the future, when these interns become licensed, we're improving the care for those living with ALS. When they start serving, they can specialize. They can say they served this community and have experience serving this community. We're building relationships and encouraging future collaborations with the University of Iowa on mental health program for other projects. We're expanding the depth of our chapter service provision, and always have with our collaborations with the universities. We're expanding the training opportunities for the counseling program and advancing the academics institution's mission. And then we're offering opportunities to apply ethical decision-making models that are really unique. I mean, it's very unique to have an individual session with a caregiver present and not provide couples therapy, and to have to negotiate technology issues and concerns. The barriers are rapport building is more difficult by the phone and virtual platform. The virtual platform itself can be a barrier, and it is important. So we definitely recommend getting that in place before you launch anything. That would allow for a more comprehensive intake process and record keeping. And then you definitely need a chapter staff with credentials to supervise them for interns. And then there's the question, is there still a need for this kind of program? Because now Medicare is covering the cost of virtual counseling. However, I have discovered that there are very few practitioners that accept Medicare for covering the cost of counseling because it's a much lower rate of reimbursement. And then there's the internet connectivity and issues that arise when you're meeting virtually. So the recommendations to the field: establish a virtual platform for facilitating the mental health program beforehand. Explore grant opportunities for that if you need to. Emphasize the education you're providing on ALS to the interns. Very specific client needs and nuances, as well as caregiver needs. And I would recommend considering offering couples and family counseling. I think it would be a very valuable addition, just a necessary skill set for myself, as well as any other supervisor would need to have that skill set to offer that support to the interns. And then finally, I always highly recommend collaborating with university programs. You're increasing the services and supports for clients living with ALS today, but you're also improving that care in the future with the future professionals education. If you have any questions, you can reach out to myself or Aaron Barnes at the University of Iowa. And I thank you for your time, and that's it.
Thank you very much, Krista. That's an amazing program. And if anyone wants to put a question, I think we might have time for one question, but I think what you described was that you came up with this idea, we're going to use interns. And next thing you knew, it's not quite that easy. It wasn't just like a straight line. Here we are, here they are. It seemed like it became much more complicated. Would you be willing to share that, like some of the things that you had to go through? So if other places want to do that, they would have that, they wouldn't have to start from square one.
Yeah, I think first you have to get a partnership with a counseling program. You have to identify a university that you have good relationship with and make a connection there. I really think it would have been great if the interns could shadow the mental health counselor at the clinic, and she could provide some supervision, and that would be a really easy, a seamless way to make the referrals to the clients for counseling. But this works too. and I think that, if there's any way that you have a chapter staff with credentials. I mean, I have done therapy with individuals in my past history of work. So my experience is valuable in this situation because I can provide that internship, that supervision myself. But if a chapter has somebody who is a licensed independent social worker or a therapist, they could provide that supervision. Okay. So, yeah.
And you had one student the first time, and then the
second.
Or is that the limit?
Well, no, it was about the hours. So this semester, fall semester, is the first internship that the interns kind of get their feet wet and start. And then the second semester, they each have to do 20 straight clinical hours themselves a piece. And then the first semester, it's 10 clinical hours a week a piece. And we could support 20 hours a week. So that being said, that's why this next semester we'll have one again, and that will be fine for 20 hours a week. So.
Well, thank you so much. I think there were a lot of people saying how great the presentation was. And I think it's a program, and it's just an idea that others may consider as well. So thank you for sharing.
Yep, my pleasure.